Paul, to start us off, Bell's palsy, it is an isolated, spontaneous peripheral impairment of the seventh cranial nerve, and there should be no other neurologic or systemic manifestations or symptoms. And Paul, what are like some of the typical things we might look for if we're examining someone or just taking a history?
Yeah, so I mean, your classic findings that should make you think about Bell's palsy if someone has a facial droop with forehead involvement, which is the thing that's going to come up on all the boards and is also what you see in real life. Patients may mention a change in taste. I have never seen this in reality. Hyperacusis is supposed to be heard. I'm thinking about this, Matt. So it's apparently the paralysis affects one of the bones that sort of helps actually tamp down hearing. So if it's affected, then you actually hear louder in that ear. I don't know how you differentiate that from actually feeling like you're hearing less in the unaffected ear, but that's a question for a different day, I guess. And then difficulty closing the affected eyelid is also sort of classic for this Bell's
Yeah.
palsy. The thing to bear in mind about this, Matt, is that the timing can be helpful here. So Bell's palsy tends to develop gradually over time. So anywhere between, it can develop over 48 to 72 hours, as opposed to strokes, which is obviously the differential that you're most terrified about, is something that happens relatively acutely. If you have someone that comes in after waking up and has symptoms, that can make things a little bit murkier. But in general, Bell's palsy develops a little bit more slowly, and stroke is going to be something that is pretty acute in presentation with